Hi everybody, and welcome to our module on hematuria. Hematuria means blood in the urine, and clinically we classify hematuria based on whether it's microscopic or gross. Microscopic is when hematuria is seen on urine microscopy. This is an example of microscopic hematuria at the top right side of the screen here. These are all red cells that you can see under the microscope when you examine a urine sample. And microscopic hematuria can be due to many causes, but you should be aware that it's often due to glomerular disease. When evaluating a patient with hematuria, one thing you want to think about is, do they have glomerular disease? Because if they have glomerulonephritis, then they're at risk for developing renal failure. So a patient who has microscopic hematuria only should be considered to possibly have glomerular disease, although it can also be due to other causes like infection and kidney stones. Gross hematuria is urine that is grossly red. This is an example of gross hematuria on the bottom right side of the screen here. And gross hematuria is usually not caused by glomerular disease. It's usually caused by something outside the glomerulus. It could be a kidney stone, it could be a kidney infection. And importantly, in a patient with gross hematuria, if you don't find an obvious cause like a kidney stone or a kidney infection, you need to do a workup for bladder or renal cancer and rule out those diagnoses. So clinically, we can classify hematuria as microscopic versus gross, but we can also classify it in terms of the source of the bleeding. And when we do it that way, we talk about glomerular bleeding versus non-glomerular bleeding. So glomerular bleeding, like the name implies, is caused by some problem in the glomerulus. Often it's glomerulonephritis or some other cause of nephritic syndrome. Glomerular bleeding is more likely to be microscopic than gross. Patients won't have any symptoms of infection of the bladder or kidneys like dysuria or flank pain. And when you examine the urine, you will often see misshapen red cells in patients who have glomerular bleeding. These are called dysmorphic red cells. When the red cells move through the lumen of the nephron, they become misshapen, and that makes them dysmorphic. Also, as red cells move through the lumen of the nephron, they can form red blood cell casts, and we'll talk more about this later. When there's a problem with the glomerulus that allows red cells into the urine, it often also allows protein into the urine. So proteinuria commonly goes along with glomerular bleeding. And as I said before, the classic cause is glomerulonephritis or some other cause of nephritic syndrome. Non-glomerular bleeding is more likely to be gross than just microscopic. These patients can have symptoms that suggest the cause of non-glomerular bleeding, symptoms like dysuria in a urinary tract infection or flank pain and pyelonephritis. The red cells of non-glomerular bleeding are normal. They are not dysmorphic because they have not traveled through the lumen of the nephron. And there's usually no protein in the urine in non-glomerular bleeding because the glomerulus is working normally and it's keeping protein out of the urine. And there are many causes of non-glomerular bleeding. Kidney stones and infection are common causes, but also cancer, as we talked about earlier. When patients have gross hematuria, you can get some clues as to the cause if you ask them when they see the blood in the urine. Do they see it initially when they begin urinating and then it clears? Do they see it only at the end of urination, in other words, at the terminal phase? Or are they able to see evidence of hematuria throughout the process of voiding? When there's hematuria only present initially that then clears, this usually indicates some injury to the urethra. This could be trauma or this could be urethritis. For example, patients who have a Foley catheter inserted often have trauma to the urethra. When you remove that Foley catheter, those patients will have a little bit of initial hematuria as they wash that blood out of the urethra, but the hematuria will clear as the process of voiding goes on. Patients that report that their urine initially appears normal but then takes on the appearance of hematuria towards the end of the voiding process, in other words, they have terminal hematuria, these patients usually have some problem with the bladder or the prostate. This could be cystitis, this could be stones or cancer of the bladder, or it could be prostate cancer. So the idea here is that initial hematuria is towards the distal end of the urinary system like the urethra. Terminal hematuria is towards the more proximal end like the bladder or the prostate. And then finally, if patients report evidence of hematuria throughout the process of voiding, this usually means that the urine is being produced and sent to the bladder with blood already mixed in. So this usually indicates that the problem involves the ureter or the kidneys. This could be pyelonephritis, this could be renal stones, this could be upper urinary cancers. But the idea here is that all the urine being produced and sent down already has blood mixed in, and therefore there's going to be evidence of blood throughout the voiding process. On this slide, I've listed some selected causes of hematuria. Some of the most common are urinary stones and urinary infections. Stones present in the kidneys, the ureter, or the bladder can all lead to hematuria. It's usually gross hematuria. It's not going to have evidence of glomerular bleeding like dysmorphic red cells and cast. The same is true for infection. Infection of the bladder, which is cystitis or pyelonephritis, causes various forms of non-glomerular bleeding and usually gross hematuria. Cancer can cause hematuria, cancer of the kidney or the bladder. As I said before, glomerulonephritis causes glomerular bleeding. And then finally, patients who are coagulopathic can bleed into the urine, not because of some lesion in the urinary tract, but simply because they don't have a normal clotting system. Listed on this slide are some of the tests used for workup of a patient with hematuria. The first one is the urine dipstick. The urine dipstick tests for all these items listed on the screen here, everything from the presence of leukocytes to the presence of glucose. And you will see that one of the elements of the urine dipstick is blood, and what it really tests for is heme. So if the dipstick indicates the presence of blood, that means that there is heme in the urine, and that usually means there is hematuria, although we will talk about other causes of heme in the urine later in this video. You want to look at the urine under the microscope when a patient has hematuria. This allows you to see red cells and white cells. You can also identify dysmorphic red blood cells or urinary casts. The physical exam and the history are important. If the patient has flank pain or symptoms of a urinary tract infection, this suggests infection is the cause of hematuria. And lastly, I've listed a couple of other tests used in a workup of hematuria. One is cystoscopy, which we'll talk about in a minute. This is very important if you suspect bladder cancer. And a CT of the abdomen is often done if a cause of hematuria is not obvious. This can identify masses in the kidneys and bladder. So now let's talk about cystoscopy. Cystoscopy involves the insertion of a camera called a cystoscope through the urethra and into the bladder, and it's used for the diagnosis of bladder cancer. And when working up hematuria, remember that cystoscopy is always going to be used after you've done a renal ultrasound or a CT scan. Ultrasound and CT scans are non-invasive tests, and they can show the diagnosis that's causing the hematuria, for example, a kidney stone or a renal cancer. Only if you do these tests and they don't show a cause for the hematuria do you proceed to cystoscopy, which is an invasive procedure. On your board exams, they will describe many different forms of urinary casts. Casts are cylindrical structures formed when substances move through the lumen of the nephron. Anytime a substance moves through the nephron, it's going to be compacted into a small structure called a cast. Red blood cell casts are what are seen in glomerulonephritis and the nephritic syndrome. I talk about this in another video. White blood cell casts are usually seen when there is pyelonephritis, meaning infection of the kidneys. However, they can also be seen in interstitial nephritis, which is a tubulointerstitial disorder that I talk about in another video. Hyaline casts are seen anytime the urine is concentrated. Usually this is seen in a patient who is dehydrated. There is a substance called the Tam-Horsfall mucoprotein that is secreted by normal tubular epithelial cells, and it will form into a hyaline cast when the patient is volume depleted and the urine is concentrated. Waxy and broad casts are classically seen in advanced chronic kidney disease. And finally, granular or muddy brown casts are what you see in acute tubular necrosis. These are casts that are formed from dead tubular cells dying as a result of tubular necrosis. Let's talk about some other pigments that can change the color of the urine besides blood. The first one is myoglobin. Myoglobin is found in muscle cells, and it spills into the bloodstream and into the urine in patients who have rhabdomyolysis, which I talk about in another video. It will turn the urine red, and because there is heme in myoglobin, the dipstick will be positive for heme. However, if you examine the urine under the microscope, you will see no red blood cells. So the classic finding in a patient with rhabdomyolysis is red urine, a positive dipstick for blood, but remember that only means that there's heme and then no red blood cells on urinalysis. That means there's myoglobin in the urine, usually caused by rhabdomyolysis. Bilirubin can appear in the urine in the setting of hemolysis or biliary disease. It will turn the urine brown, like shown in this picture on the screen, and bilirubin is one of the things that's detected by the urine dipstick. And then finally, it's very high yield to know this for board exams because it often comes up. Rifampin is a drug used to treat tuberculosis, and it gets concentrated into the urine and turns the urine orange. And that concludes our module on hematuria.